let's talk Kentucky. Now, again, I'm a Kentucky guy. I've spent a lot of my professional career, most of my professional career in Kentucky itself. New place or other places seem strange and awkward to me, but Kentucky's one that I kind of know a little bit better. I'll hit on kind of the important parts of it. Kentucky's good because it's a little simpler than Ohio, but it also offers you a little bit less options. There's trade-offs, there's good things and bad things. If you're deciding on where you want to live based on where you want to die, I recommend God's country, the great state of Kentucky, Commonwealth of Kentucky. Okay. In Kentucky, there's basically 3 ways that you can be a DNR, which doesn't complicate things at all. You can have an EMS DNR form through the Kentucky Board of EMS. You can have what's essentially the Kentucky Board of Medical Licensure, the Doctors Board DNR form, which is a MOST form, Medical Order for Scope of Treatment form. Or you can have a Kentucky Living Will, which is through the Attorney General's office. All these sort of suffice to lay your wishes out in front of somebody. But EMS-wise, we can only act on 2 of them, and that's the EMS DNR and the MOST form. The Kentucky Living Will form is a little bit different, and it's not really an EMS-centric thing, which is unfortunate. Here is the standard one that we're usually used to seeing, and that you're going to see most of the time, the Kentucky Emergency Medical Services Do Not Resuscitate Order. This is filled out by you, by a person, by a civilian, by the person that is theoretically wanting to be DNR, as opposed to the Ohio one where it has to be signed by the doctor, or supposed to be signed by the doctor. So you can print this off the K-Beam's website and fill it out, and you can be a DNR tomorrow, essentially, or today. It has patient's name. It has their surrogate's legal name, if that's the case. And then it says, basically, I understand that I want to be a DNR, that no medical procedure to restart breathing or heart function will be performed, including, more specifically, insertion of a tube into the lungs, electrical shocking of the heart, cardiopulmonary resuscitation, will be started by emergency medical services personnel. So if you have this, then you won't get intubated. And this is just if you arrest. If you stop breathing, you're not going to get intubated. If your heart stops, you're not going to get drugs shocked, et cetera, et cetera. I understand this won't prevent EMS from helping me otherwise. If I break my leg, it's just a thing that I have if my heart stops. I can revoke this at any time by telling people that I want to be resuscitated. Any attempt to alter or change things on here will make it invalid. So you need to fill out a new form if something changes. And then it also says, I understand that I have to be able to show this to DNR, or show this DNR form to the EMS providers when they arrive in order for it to be workable. And it is supposed to be in Kentucky a wet copy, essentially. So there's a signature line down at the bottom. It's supposed to be signed by the patient in ink and dated on that form. And a copy is kind of, while it does, again, relay your wishes, a copy in and of itself is not really kosher. If you had what looks like a great DNR form for a patient that clearly wanted to be DNR and you honored the copy, I doubt anybody's going to give you trouble over it, but it's not actually supposed to be cool. It's supposed to be an original signed copy that the patient acts, or that you are acting on. Now, it's also supposed to be notarized, which very few people do, but some people do because they're fancy like that. And if it is, there's supposed to be the seal down at the bottom and like the notary signature and that kind of stuff. Most people that I've seen will have it witnessed by 2 people. It is supposed to be witnessed by people that are not related to you in order to be valid. So you may see it notarized, you may see it witnessed, you'll certainly see it signed. If it doesn't have all those things, either a notary or witnesses, or it's not signed by you, then it's not supposed to be, not actually supposed to be valid. You can also have this thing down at the bottom, which is supposed to be signed as well. You can cut off the bottom of that piece of paper and stick it into a hospital bracelet and put it on the patient's ankle or on their wrist so that it is always there, so you don't have the problem of, oh my God, where's the DNR form? It's in the safe and we don't know the combination to the safe or something like that. You can also turn it into a wristband. That works. The fine print about it is, again, on the back, which most of what we covered already there. This is designed for the pre-hospital setting, not necessarily the in-hospital setting, and it is supposed to be in the pre-hospital setting specifically. So if you fill it out at a hospital and take it home, it works. Or if it's in the a long-term care facility or something like that, it's supposed to work. This doesn't mean that you don't do other stuff with them. There's not really a comfort care option here where you don't resuscitate them up to the point of it. This is the way that it is. Again, it's supposed to be the original signed, completed DNR order or the bracelet that is readily accessible to EMS. If you know that death is imminent for this person, if you get hit by a car, it's hard to produce your DNR form. But if the person is dying at home, you should probably have it next to the patient so that if somebody walks in and finds the patient in arrest and calls 911, it's easily accessible. No, DNR. Got it. One other thing that's a little bit funny about Kentucky, you personally can revoke your DNR at any point. You just tear the thing up, you burn it, you say, I don't want to be a DNR anymore, or something like that. Interestingly enough, your legal healthcare surrogate can also cancel this if you can't make medical decisions. So in Ohio, your wishes are supposed to carry forward here. What this says is that, or by destroying the order or person on whose behalf it was executed, or by the patient's legal health care surrogate, which seems to say, I think the spirit of it is that you can turn this off at any point if you decide you don't want it to be the case. What that actually reads is that if your wife, my wife comes in and says, he can't die, take that DNR order, and then it's no good anymore because they're the medical decision maker at that point, because I can't relay those things. Now, again, that's not the spirit of it, but that's what it practically reads as. And if there's a lawyer out there that says, no, lovers, you got that completely wrong, tell me, but I've never been challenged on it thus far. That's the EMS DNR in Kentucky that you may find. There's also the Kentucky MOST form, or Medical Order for Scope of Treatment. Ohio doesn't have a MOST form. There's some legislation out there, but as far as I know, that has not actually gone anywhere so far to be that legally recognized document. You still have the DNR form. They are sort of similar, but a little different. Now, the MOST form is supposed to be on that pink sheet of paper as you kind of see here. It's supposed to look like that. Would you not honor it if it was on white paper? Well, that's silly. It is, of course you would. It is a two-sider, because why would you put anything important on just one side of the piece of paper? And looks thusly. So there is legislation in Kentucky, not legislation, there is law in Kentucky that says that this works. It's a thing. It specifies exactly how it's supposed to be printed out and what it does. And the acceptable and prevailing medical practice shall be for a licensee to use the standard, that's a doctor, or an APRN or a PA, the standardized MOST form developed and adopted by the board. So what this does is, again, it's physician's orders essentially to determine how the patient is going to be treated. It is filled out by a physician. It's supposed to have the patient's consent, and they're supposed to review it with the doctor and all that kind of stuff, but it's a doctor's orders at this point. Here's what it says. The top of it has, demographic data on the patient, but then it's got essentially a DNR form. And you can say they're going to, do you want CPR? Yes, no, kind of thing. And you're supposed to only click one or check one of those. Yes, attempt resuscitation, do not attempt resuscitation. Then below that, there is this scope of treatment, which makes it different than a DNR form. So there is full scope of treatment where you intubate the person, even if they're not in arrest. Do you want to be intubated? Do you want to have advanced airways, mechanical ventilation, defibrillation, cardioversion, IV fluids, all that kind of stuff? And comfort measures. Take the person to the hospital if they're dying or something like that. That's like the full one. That goes all the way down to comfort measures, which is keep me clean, warm, and dry, and maybe give me medication for pain and suffering, and maybe give me oxygen suction and that kind of stuff. Don't take me to the hospital unless you can't keep me comfortable at home. And then there's a thing in the middle that you can kind of fill out and specify, like, I want fluids, but I don't want pressors or something like that. There's also an other instructions box, like where the patient, the person can write, or the physician can write, patient does want pressors, they don't want chest compressions, and he wants a glass of whiskey before you take him to the hospital or something like that. Below that, outside of the immediate stuff, there's questions about like whether or not they get antibiotics, whether or not they get artificially administered fluids and nutrition, like would they want a feeding tube, et cetera, et cetera. And then there's a box at the bottom that says who they talk to fill this out, like who's helping to make these decisions. And also whether they have a healthcare power of attorney or a living will or a medical directive or anything like that. And again, who fills this out? It's supposed to be the doctor that actually fills this out in consultation with the family and with this stuff. It's not really, you're not supposed to hand this to the patient and say, here, mark down what you want and write on here what you want. It's supposed to be the doctor talking to you and interpreting what it is that you want. And then there's a thing at the bottom that has both the patient's signature and the physician's signature on it. The backside mostly just has directions for it and doesn't add a whole lot into our understanding of it. You can, again, change this if the patient's status changes or if the patient decides that this is not what they want. You should communicate with them or with their surrogate. There's no requirement that you have to have it. You are supposed to send the original form. So, again, if you have a copy, it says what the patient's wishes are, but you're not really supposed to honor the copy. You're supposed to have, theoretically, an 8.5 by 11 bright pink sheet of paper that's printed on both sides in this way and then filled out in ink, signed in ink by the responsible person. On the back, there is supposed to be a requirement that you review this yearly or earlier if there's some sort of change in the patient condition, so that you're not following something, last year he didn't have cancer, this year he has cancer, and so things change. That's supposed to be documented at the bottom. I've seen very few of these actually ever filled out, the form in general, and I've never seen one reviewed down at the bottom, but it's supposed to happen anyway. So those are the two ways that you could be a DNR in Kentucky. You could have an EMS DNR, which is fairly straightforward, and then you can have the Kentucky Most form, which thankfully at least does spell out a little bit more about what you would want, rather than the Ohio one, which is the same functional thing, but doesn't necessarily say exactly what it is the patient wants. If you have any question, ask the patient if they can tell you, or ask the decision maker about what the patient will want, because again, it is what the patient's wishes would be. That's kind of the important part about it. Cool, great, good to talk about in a nice 72-degree, essentially, office when we don't actually have to go out and deal with a screaming family and a patient covered in vomit or blood in their house. What do you do when it's 3 a.m. and the poop kind of hits the fan and things actually happen? Let's do some of these scenarios. So this is, again, on that poll everywhere thing. If you haven't filled it out, go ahead and open it up, and you can answer along as we go through it, and I'll provide additional information and that sort of stuff. Hopefully it is actually functional and it worked. So let's do some cases. All right. In this case, patient is in arrest. You've intubated the patient. The niece shows up with a DNR form. We're starting relatively easy here and stuff that we talked about. You've intubated the patient. Niece shows up with a DNR form. What do you do? Extubate, leave the scene, proceed with resuscitation, stop compressions, or stop compression, stop drugs, stop ventilation, call the coroner. And what we find is that pretty much everybody is on the right track and says, yes, when they are now a DNR, whatever we've done to this point, we will leave per local requirements and call the coroner and get the police to take over the scene, generally speaking. That's pretty standard practice there. Some folks say a little bit proceed with resus, extubate and leave the scene. I don't think I'd extubate them without the coroner doing their assessment and that kind of stuff. Generally, leave lines. If you're going to terminate on scene for whatever reason, you generally leave lines, tubes, and interventions in place. All right, that's for the arrested patient, yeah. You throw a wrench in it. Patient's in arrest, you've intubated the patient, the niece shows up with a good DNR form, and the patient gets ROSC. As you're reading the form, your partner says, hey, he's got a pulse. what do you do now? Let's see what everybody says. We generally said, I gotta get out of the way here. Here we go. That we would then transport this patient to the hospital. Some of us said proceed with resus, and a couple of us said stop compression, stop drugs, stop ventilation. Basically, they're DNR at that point. The important thing here is that once they get ROSC, they're not actually arrested anymore. So even if they are DNR like comfort care, if they're just comfort care arrest, then like he's already arrested, you've already done the stuff, and now he's not arrested, so he's just back to being a patient. So you wouldn't necessarily stop for that one. If he rearrests, then yes, I would say don't do chest compressions, don't bag the patient anymore, don't give them cardiac drugs and that sort of thing. That makes sense. But if they get ROSC and you've got them intubated, you probably need to take them to the hospital so that they can sort that out. And they can extubate them there, that sort of thing. All right, here's another one. The patient, get it there. Patient is unresponsive, but they're not in arrest. They have a good pulse, but they're not maintaining their airway at all. They're kind of choking on their saliva. They have let's say they've had a bad stroke or something like that. And you think you need to intubate them, and you have the means to RSI. So you push ketamine and sucks to intubate them. As the ketamine and sucks are in, the daughter shows up with a MOST form that says, "Do not intubate me under any circumstances." What do you do? This is a actual real case, or something similar to it that I reviewed. Good. We got pretty much the right track here. Now, I think in this case you got to ask, what is the right thing to do to the person? Number one, they're paralyzed now, and that is incredibly painful to die just from asphyxia because you can't move. I can't think of a much worse way to go other than that. So. I think it is completely unethical to say, well, I paralyzed him. He wasn't dead before, but I guess he's dead now. We'll let him asphyxiate. I think that's totally wrong. So what I would recommend is BVM him, because you can BVM through the sucks. You give him a jaw thrust, maybe put an oral airway in, help him breathe. Because he's not dead at this point, help them to breathe through non-invasive means until the paralytic wears off, and then probably take him to the hospital. In the case that we reviewed, it was the patient was essentially, they just kind of walked out at that point and stopped everything, and that's patient Brady's down, and then they go into arrest. I don't think that's the right answer. But you can bag them. That's a pretty reasonable thing, and you don't have to intubate them necessarily. So the best answer, I think, is go ahead and BVM them through it till the paralytic wears off, and then probably take them to the hospital there. Again, they're not in arrest at this point, not in arrest. If they arrest, okay, we're done. Here's another situation. Patient has advanced MS. They have a perfectly executed DNR form, but the husband says they are 10 weeks pregnant. She just found out. She's in arrest. What do you do? Most of us say here, most of us are going to say that you do everything. And then some of us say no further treatment, leave scene. Cool. The exact right answer is a little different from state to state. In Ohio, it's fairly clear that you can't be a DNR if you're pregnant, generally speaking. Unless the pregnancy is known to be blighted and there's no chance the baby's going to survive, which you would never know that. You always have to give it you lean on the side of survival, and so you basically would just have to say the patient really can't be DNR. In Kentucky, there is a little bit of a caveat to say that exact thing, which is if two physicians sign off on a statement that nothing is going to help bring this baby to term, and that there's no chance, the patient's already already in a persistent vegetative state, although they're 12 weeks pregnant, they got shot in the head, and nothing is going to help this baby come out or something like that. They could sign that. There is a way to do it, but it's not common. Generally speaking, pregnant people can't really be DNRs very well. But again, you have to kind of know where you're at here. So the best answer is probably to do everything and take them to the hospital and let them sort that out. By the way, this is not terminating resuscitation. This is what happens if you are a DNR specifically. Terminating resuscitation may be a little bit different. There's still medical futility out there. Okay, anyway, talking too much. Patient is in arrest. Husband rips up the DNR form in front of you. What do? Well, it depends on kind of where you are. If you're in Ohio, you may say there's still a DNR. Patient's wishes were clear. Husband doesn't get to make that call. Your wishes make more sense, or your wishes carry more weight than that of your decision maker. You could say that. If the best answer overall is depends on where you are, probably. In Kentucky, the DNR form is rescinded by the medical decision maker, and so, okay, I guess we're not a DNR now. It's a little funny, but it depends on where you are. And again, what is the actual patient wishes? What would I actually do here? I'd say call a doctor and get them to talk to the husband. And let's say, wait a minute, let's take a step back here. She clearly didn't want this. Let's talk this through. And again, if you are a lawyer and you disagree with my interpretation of what's clearly written on the form, please let me know, because I would love to hear about it from somebody that's not a doctor. All right, here's a little tricky one. Patient's in arrest. The adult son and daughter are there, and they say she's a DNR. Adult daughter number 2 says she's a full code. Patient's mother, who is also there, says she's a DNR. Husband has advanced dementia and says full code, and also there's spiders and snails running up the wall, and watch out for the aliens. There's one other child of the patient who's skiing in Colorado and says should be available by phone in about 90 minutes, but can't really talk otherwise. What do you do? Who do you listen to? What do you follow? Again, patient is arrested. Most of us say kind of the same thing as yesterday. Maybe a little bit different. A lot of us are saying husband is the decision maker, full code. Husband would be the decision maker. That's true, generally speaking. But this husband has advanced dementia, and he's talking out of his head. Would you trust him to be able to does he seem to have capacity to make medical decisions? If no, then he can't really be the decision maker for this person either. You can't not make your own medical decisions and have that out there. I didn't specify that per se, but I'm trying to get at that. So yes, if he was a normal person, he would be the decision maker, and she'd be a full code. In the setting of he doesn't know what day it is or where he's at or who this person truly is, then he can't really be the decision maker. So it then bumps on to the kids in terms of the hierarchy. You got a couple of kids that say full code, and you got one that says no and one that's not available. Who do you listen to? In this case, you generally go by how many of the adult children that are immediately available make the decision, like the majority of it, essentially. It's kind of a vote. So in this case, you got 2 kids that are there that say she's a full code. You can't wait for the third kid who's 90 minutes from being able to talk to you. It's 2 versus 1. This patient becomes a DNR, essentially, or you would honor that DNR. And again, that's the statutory hierarchy that's filled out here. It's a guardian, which is somebody that's appointed by the state, or a power of attorney first. In absence of either of those people, it's a spouse. And again, all these people have to have the ability to make decisions. As a spouse next, adult children following that, the majority of reasonably available children, followed by the parents of the patient, followed by the patient's nearest living relative. All right. Here is, getting to the end here, there's a no DNR form. The patient is in hospice. Family says that she would want everything done, and she's now in arrest. What do you do? Most of us say there's no DNR form, resuscitate away. That's probably the right answer. Unfortunately, hospice, while it seems to sort of say we recognize death is coming and we're not going to prevent it anymore, except if she dies, then we're going to try to prevent it. Yes, I agree that absolutely doesn't make sense, but some people do that. So do not resuscitate, or hospice, unfortunately, doesn't even necessarily mean do not resuscitate anymore, which I hate. But it's there. They let them do it. I don't understand it, but it's what happens. I would say the best answer is probably, yeah, there's no DNR form. You should go ahead and resuscitate this person. I would do a combination of probably that and the last one, which people took, which was go ahead and start resuscitation. Keep the family in the room so that they watch you do these chest compressions on the frail and broken body of their cancer-ridden family member. and can kind of determine, yeah, she actually wouldn't want this, let's stop, and then call medical control from there. So, combination of probably the second one and the fourth one. All right, there's no DNR form, or sorry, there is a DNR form. It's a copy. What do? The patient's in arrest. Again, sort of depends on where you are. The copy doesn't technically count, but I think you'd be hard pressed to say that it's ethical to not act on the copy. But legally, you're not supposed to. You're supposed to like confirm with medical control and all that kind of stuff first, and get everybody involved. You're not supposed to just honor the copy, at least in Kentucky. In Ohio, the law seems to be a little bit more lax on it, and the DNR would still be honored, generally speaking. So again, depends on where you are a little bit. There's a DNR form. The skilled nursing facility staff says it's their policy. You have to transport this person. Nobody dies here. Get them out of here. What do? In this case, the ethical thing is clearly to say, I'll talk to your director of nursing or whoever, but we are not resuscitating this person, and we contact the coroner. If the patient dies and medical control is a fine way to do that. I wouldn't take the patient out of the scene, honestly, because that's, the coroner still needs to be involved. If there's a death investigation, it needs to happen still. You shouldn't move the person if we're not doing anything with it. Medical control would be good to talk to those folks and say, you're insane, this person's DNR, we're not doing it. But yeah, if you die in Wendy's, we may move the patient out of sight for people for the sake of privacy and reason. But otherwise, just because he dies in Wendy's, if he's got a good DNR form or a thing wrapped around his ankle, we're not going to resuscitate the guy. We're not going to take him to the hospital. And again, you got to work that out with what your coroner wants done. I think this is the last one here. There's no advance directive. The family begs you not to do chest compressions, and the patient's in arrest. What do? Well, if there's no EMS DNR form or anything like that, even if the family's begging you, you probably should go ahead and start chest compressions, but immediately call medical control. You could make the case, all right, we'll go ahead and start an IV as well, and we'll try to bag him, maybe hold off on on intubating right now. But yeah, if there's no DNR form, you are supposed to start resuscitating the person. A quick call to an early call, not quick, but an early call to medical control can help sort out what this means. And then you can get an order. The nice thing about being a doctor is that I can give you orders that are not necessarily protocolized, and I can talk to the family and say, yeah, family would clearly not want this. I think we can go ahead and terminate resuscitation at this point. That's within the ability for a doc to do. And give you the order to stop. All right, good talk here. Man, still talk too much about it. Even I tried to go faster. We will. I've just got a short little piece at the end of this here to finish up for the day. But a DNR, as we kind of said, indicates wishes. It is a legal document. It's something that EMS can act on. But overall, the DNR form is really indicating what the patient's wishes are. And so we should try to follow that to whatever extent that we possibly can. Patient's wishes trump the family's wishes. Power of attorney is more meaningful than a spouse's opinion, which is more meaningful than the adult children. Then the parents follow that in terms of decision making. Online medical control can solve a lot of our problems. And don't feel bad about calling. It's our job to help figure these things out. That's why we make the big bucks. And then know your local DNR processes. Know what is going on in your state and what you're going to do with these folks and what you have to have, and it'll make things more clear at 3 a.m. rather than trying to figure it out de novo there.